All right, so we're going to be reviewing mechanical ventilation. This is going to be my most up-to-date lecture. I do have a YouTube video that was previously posted that has a lot of the same content, but some of the things that have been updated in this video are the scenarios, pediatric mechanical ventilation, and then some stuff involving adult mechanical ventilation. So this is going to be the most up-to-date lecture. We're going to be discussing BiPAP versus CPAP, the indications, contraindications, the differences between them. We'll also do a scenario to kind of help incorporate BiPAP. We're going to talk about an adult intubated patient and a pediatric, and then different approaches when it comes to managing a patient who has been intubated with obstructive versus injury approach, and then scenarios at the end to kind of help bring everything together. I always love to start off with this question because I really want you guys to think about how your treatments are directly impacting the underlying physiology of what's going on with your patient. So providing positive pressure ventilation is going to decrease your preload, which is going to decrease your cardiac output, which means that it's directly going to have a response on your hemodynamics. So your blood pressure is more than likely going to lower once you start positive pressure ventilation. If somebody's blood pressure is already high, like a CHF patient, this has direct benefits to them. If you have a patient who is already hemodynamically unstable, like a septic patient with pneumonia, then an increase of positive pressure without you directly treating their blood pressure could have very negative effects on their overall hemodynamics and cause severe hypotension. So you really have to understand underlying physiology of what's going on with your patient whenever you're providing treatments. So if we look at this graph, it basically outlines everything I just said. Increase in intrathoracic pressure, decreases venous return, which means there's less blood coming back to the right side of the heart, which means there's going to be less blood coming back to the left side of the heart. Your overall cardiac output is going to drop. But if you are that patient who is fluid overloaded, like I said, there are benefits to that, and that is on the right side of the screen, your afterload and the workload on that left side of the heart is going to decrease. So that person with heart failure, their heart is not having to push against increased resistance because now by you providing positive pressure, you're helping lower the workload on that heart, which should hopefully overall help with the amount of pulmonary edema that's occurring inside their lungs. So how does positive pressure cause trauma? So you have to think about when we were carrying adult BVMs, when you were taught how to ventilate somebody with a BVM in school, you were always taught to squeeze the bag just enough to get chest rise because overinflating the bag could cause barrel trauma. And barrel trauma has obviously negative effects on the patient's overall outcome. So whenever we are applying tidal volumes on a vent, we're always using ideal body weights and we're always using the minimal amount of volume necessary to create chest rise and adequate vital signs. If we are overinflating somebody's lungs, we are going to cause barrel trauma. So this is what's currently used in our airway bag. It's more than likely what's being put on the patient first. A lot of us don't typically bring the vent in on breathing problems unless maybe the notes sounded really bad. But for the most part, we're probably starting off here. As everything you need is super easy to put together. The big thing that I want you guys to know is that this whole kit only provides 30% FiO2. So that's very important to know. Even if the patient likes CPAP, there is a benefit to putting them on our Zol vent because you can directly control the amount of FiO2 that the patient is getting with our Zol vent. And we're talking about indications and contraindications. Indications is obviously going to be somebody who's in moderate to severe respiratory distress, whether that's from wheezing, pulmonary edema, or somebody who may be involved in some form of drowning. Patients that you don't want to put a CPAP on are anybody who can't control an airway, who's unconscious, who's not breathing, who has chest trauma, potential pneumothoraxes. Those are your common ones. I like to say hypotension is a relative one. It may not be, if they are hypotensive, putting them on CPAP or BiPAP may not be the first thing that you do. Probably the first thing that you're doing is non-rebreather, IV, and then some form of fluids and maybe pressors. But if you're able to treat their blood pressure you should hopefully be able to also apply CPAP or BiPAP if you feel like that's what's absolutely needed to keep that person alive. You just have to combat physiology based off of how you know positive pressure directly affects hemodynamics. So CPAP stands for continuous positive airway pressure. It allows for a constant pressure throughout the entire respiratory cycle. It does not allow your alveoli to completely collapse, so it helps stent the alveoli open so that you're able to have better gas exchange. CPAP is a great tool to help oxygenate because you can change your FiO2 and your PEEP. Through that, you're hoping that decreases work of breathing, improves shunting, and then opens up any collapsed alveoli. The downside is if they're already extremely fatigued, it's not going to benefit that patient. This is where BiPAP has the greatest benefit for the patient, is that CPAP helps oxygenate, BiPAP helps oxygenate and supports their spontaneous ventilation. Something we'll discuss on the next slide. BiPAP or also bi-level, which on your vent you'll see a BL, they both mean the same thing. BiPAP essentially means that you have two different pressures. These two different pressures basically work by assisting somebody's own spontaneous respiration. What that means is instead of CPAP being that constant flow inside your face, BiPAP is now working with you. As you take a breath, I provide support. As you breathe out, you're breathing against a PEEP. The two different settings are IPAP and EPAP. EPAP is essentially your PEEP. So they both, EPAP and PEEP mean the exact same thing. So if we're worrying about how do I oxygenate somebody on a BiPAP, the two settings don't change. It should be your FiO2 and then you adjusting the PEEP as needed, something we'll talk about in the next slide. As mentioned previously, this helps the patient because it's more comfortable for them, and it's great for oxygenating and it's great for ventilating. So one big thing that you guys have to put into your brain is that the difference between the two numbers in BiPAP mode is called pressure support. So your IPAP is your inspiratory positive airway pressure, your EPAP is your expiratory positive airway pressure. Typically when you're putting somebody on BiPAP, you're starting at a setting of 10/5. Essentially you have 10 of inspiratory pressure and 5 of PEEP, because remember EPAP is PEEP. The reason why this number should always be minimally 5 is because if you allow the gradient to get closer together, all you're doing is taking away the amount of support that person's getting. So we likely typically keep that number at least 5. And we'll talk about in the next slide how increasing the difference between those two directly affects the patient. But at the end of the day, your pressure support is what's improving their ventilation and decreasing their work of breathing. So for a patient who is struggling to breathe, you increasing that pressure support is going to hopefully provide more support to their spontaneous breath. Increasing your EPAP and your FiO2 is going to have direct changes on that patient's ability to be able to oxygenate. So in a hypoxic patient, you're going to slowly increase the PEEP by increments of 2. That's typically what the recommendation is. Your FiO2 is probably already at 100%, so there's only one thing that you can change. Now, in the previous slide, we talked about how your pressure support, which is the difference between the two numbers, has to be a minimum of 5. So whatever you do to the bottom number, you have to do to the top number to maintain that same gradient. So if I'm starting off at 10/5, an IPAP of 10 and an EPAP of 5, and I want my PEEP, which is your EPAP in BiPAP mode, to be 7, then you're going to have to increase your IPAP by how many points? Hopefully you said 2, because you want to keep that gradient the same. So here's the example, you're 10/5, now you're 12/7. The gradient of pressure support is still 5, but you just helped improve your oxygenation by improving the PEEP to 7. Now, a hypercapnic patient or a patient who is struggling to breathe, you want to widen the gradient between those two numbers. The reason why that is because the bigger the difference between the two numbers, the more support you're providing them. Remember, in the previous slide, we said pressure support helps improve ventilation and decrease work of breathing. So if I'm at 10/5 and I'm looking at my patient, there's some slight improvements, but I notice that they're still struggling to breathe, what I'm going to do is increase my IPAP. I may make minor changes because sometimes drastic changes could be very uncomfortable for somebody, but you're a clinician, do what you feel is best for the patient. For this example, instead of being 10/5, I went to 12/5. Simple math, my pressure support is now 7. Let's dive into a scenario. So you have a 30-year-old female with a history of asthma. In a tripod position, respiratory distress, talking in 1 to 2 word sentences, anxious, diminished lung sounds bilaterally. A lot of concerning things here. You have a patient with asthma who's in tripoding, who can barely speak to you, whose lung sounds, they're not even wheezing, which at least wheezing means they're moving air. Diminished bilaterally means that they're so clamped down that they're not moving any air at all. You're going to have to be very aggressive with this patient from the beginning. I'm looking at their vital signs. They're kind of matching our presentation. The patient's hypoxic, hypercapnic, they're tachypnic, and they're tachycardic. Your initial treatment is definitely trying to get albuterol and Atrovent, but that albuterol and Atrovent is not going to go anywhere unless you open them up with IM Epi, which is something that is in a BLS scope of practice at Community Fire Department, and then obviously in the ALS scope of practice. And then this is somebody that is meeting that moderate to severe respiratory distress, who's still able to follow commands, still maintaining an airway, but needs some form of support beyond just a normal nebulizer, which you can provide ANA treatments, albuterol Atrovent through our CPAP circuit in combination with getting that IM Epi on board. Now, when you think about what's actually going on here, is this an oxygenation issue or a ventilation issue? Now, we're having both. But when we're talking about oxygenation and ventilation, we kind of have to separate them a little bit. In this particular patient, it is an underlying ventilation issue. They're having a hard time getting air out, which is also now leading a hard time to getting air in, directly affecting their ability to be able to oxygenate. If we open them up with medications and some form of positive pressure, we're going to relieve that ventilation issue, which is going to lead to them being able to oxygenate better. But the primary issue here is a ventilation issue. So here's a visual for you guys to kind of show what an asthmatic airway looks like compared to a normal airway. So it's obviously our job to provide medications to relax those smooth muscles. And in this situation, it's beyond just your normal albuterol Atrovent, and we have to provide that IM Epi to help open up those airways so that that nebulized medication can get down into the lungs. So you get them into the back of the ambulance. They didn't really get any better with the CPAP, so you place them on your BiPAP. What are going to be your initial settings? So I want you guys to think about this. My initial settings are IPAP of 10, EPAP of 5. I'm just going to start there and see what happens. So can you continue an albuterol treatment with the BiPAP? Yes, you can. You have to use the blue T-piece. It should be on every ambulance. It should be stocked. This is a very important piece of equipment that you want to know is in your ambulance in the beginning of the morning, and you don't want to find out that it's not in the ambulance when you have a patient who directly needs to benefit from albuterol Atrovent through a BiPAP mask. So if we're looking at current vital signs with our initial treatment, there's marked improvement, but the patient is still having a hard time breathing, still is anxious, and is having a hard time tolerating that mask. This is a patient that is requiring additional treatments, and I want you guys to think about those additional treatments that we can give. And hopefully, as you're thinking about this, you're already on the board of, we need to get MAG, we need to get steroids, and if the patient continues to be anxious, we might need to do a low dose of ketamine. There's also changes that we can make on the BiPAP to help improve this patient's overall care. So we're going to go ahead and start that magnesium drip. Okay. We're going to go ahead and give steroids if we already haven't done that. I didn't list that there, but we should definitely get steroids on board. And then we're going to increase the pressure support. And how are we going to do that? Hopefully you guys are saying, yeah, we're going to increase pressure support by making the difference between the two numbers bigger. So instead of being 10/5, maybe we're 12/5. And what does that do? That decreases their work of breathing. and hopefully that helps improve their oxygenation. Now, if they continue to be anxious, they continue to not tolerate the mask, obviously your first step before jumping to ketamine is talking that patient through this, because being in respiratory distress and having a mask on is very uncomfortable. But if that's not working, ketamine is a great drug because ketamine bronchodilates. So you can knock out two birds in one stone. You can give them 10 to 20 milligrams of ketamine, should be enough to relax them, and then you're also helping them bronchodilate. So hopefully they become compliant with your treatment, and you're providing some underlying treatment as well with the bronchodilation. All right, let's talk a little bit about trigger. So trigger is essentially what is triggering the vent to work. What is the sensitivity level of the vent? The way that you get to trigger on our vent is when you're in BiPAP mode, and it's only in BiPAP mode that I believe that you can change this, is holding down the PIP. If you hold down the PIP button, your trigger will pop up. Your trigger is normally defaulted to -2. So the patient has to drop their diaphragm, which we normally breathe by negative pressure, create that negative pressure gradient. Once that negative pressure reaches a threshold of -2, the vent turns on and starts to provide support. So messing with the trigger is not necessarily something that you may do off the bat. This is more of fine-tuning the vent for your patient. So adjusting the trigger and making it, increasing that number, making it more closer to positive. So taking that -2 and making it -1, making it -0.5, which is about the highest you can go. Essentially what you're doing in that situation is making it more sensitive. So when we're talking about mode of ventilation, we're talking about what mode do we typically use for an intubated patient on our Zolvet. And that's going to be assist control. And I always love to ask people when I'm doing this lecture live is, what does assist mean and what does control mean? Because if you can break down that word, then you can break down what AC mode is. And hopefully you understand that assist means I'm helping you out. If I'm the vent, you want to take a spontaneous breath, I'm going to support that spontaneous breath with the tidal volume that you set. If you are not breathing, I am the vent, will control your breathing based off of the settings that the provider put in. AC mode will either assist you or control based off of what the patient is doing, if they're breathing on their own, if they're not breathing on their own. And we'll talk about the benefits and the side of the adverse effects of this mode in the next slide. To give you a visual, the tidal volume is on the top part of the screen. It's 500. In the first cycle, respiratory cycle, the patient is not breathing. They get that tidal volume of 500. In the next two respiratory cycles, the patient has dropped their diaphragm on their own. They create a little bit of negative pressure. That's why you see that little drop below the baseline. They are still getting that set tidal volume. So no matter what, they're going to get that set tidal volume, whether they're breathing on their own, which is assisting them, or if they're not breathing, controlling every aspect of their respiratory cycle. So further breaking down volume and pressure makes this very easy on you guys again. In volume mode, you literally set the volume and the pressure is going to vary. In pressure mode, you are going to set the pressure and the volume is going to vary. Okay? So you're going to inhale in volume mode until the set volume is reached, and then you're going to exhale. And based off of that, the pressure will vary each respiratory cycle. In pressure mode, you're setting the pressure, and based off of their lung compliance, creates a volume. The only issue is that that volume could change with each respiratory cycle. So you kind of have to monitor what their range and their volume is, and if their range is in an appropriate range for that patient, then you keep the pressure there. If your PIP is set at 25 and they're producing a volume of 300 for a 6-foot male, obviously 300 is not going to be sufficient enough to maintain that male patient because they're 6 foot. Their tidal volume should be somewhere between 450 and 500. You take the PIP you go up to 30 in pressure mode. Maybe that improves your tidal volumes to be somewhere within that range. It just depends on the situation and their overall lung compliance. But the big thing is that pressure mode, the volumes will vary. In volume mode, the pressures will vary. Typically, we're always going to be in volume mode. We'll talk a little bit about when we switch to pressure mode. Let's go over some advantages and disadvantages. Advantages, you're guaranteed the lung to inflate with that set volume. The disadvantages is that the vent does not take into account the pressure that it's creating inside of the chest to administer that volume. So there's a chance that the volume that you're giving could exceed pressure that is directly being applied to the lung, and you could be causing barotrauma with the settings that you have for that patient. That's why it's important to monitor the pressure when you're in volume mode. When you're in pressure mode, the advantage is that you're protecting the lung. You're making sure the pressure never exceeds what you set it to. The downside is, like I explained previously, is that volume is going to vary, and that could change with each respiratory cycle based off of your lung compliance. So you as a provider has to understand what mode you're in and how it's working, and monitor and make sure that that volume is in an appropriate range for that patient. PIP usually trips people up. PIP stands for peak inspiratory pressure. PIP is essentially the safety mode on your vent. It applies to pressures that it's monitoring in your upper airway, your endotracheal tube, your vent circuit, and your bronchial tree. It has indirectly will measure the lung compliance. So if you have poor lung compliance, meaning that your lungs are not expanding adequately with the volume we're giving due to them being diseased from some form of disease, that could cause really high pressure alarms, not necessarily because there's any issue with your equipment, but because their lungs are not very compliant with the volume you're giving them. This is how you know that you're safely ventilating the patient. So this is an example of a vent waveform. The vent waveform is typically seen through each respiratory cycle, and this is kind of breaking it down to kind of give you guys a visual of what's actually going on inside the waveform. So the highest pressure throughout each respiratory cycle should always be your PIP, your peak inspiratory pressure. The baseline at which the waveform normally falls back to is the PEEP that you set it to, which is your oxygenation maneuver. And then the plateau pressure, which is not something that we can generate on our ZOLL vent currently, but the plateau pressure offers a lot of information because it allows you to see the pressure at the actual alveoli level. So in the next couple slides, we'll be talking about peak inspiratory pressures, what it's measuring, and then a systematic way of kind of going through if you have a peak inspiratory alarm going off, like a high pressure alarm or a low pressure alarm. All right, so we're going to go over the specifics of what exactly could cause high PIP. The first one being a patient who is severely bronchoconstricted. These patients are going to lead to high airway resistance due to that severe bronchoconstriction. So there are things that we can do on a vent: optimize expiratory time, keep lower respiratory rates, all things that we'll talk about a little bit later on in this lecture. Big thing with these patients is to continue treating the underlying cause with medications. So continuous NEB treatments, IM epi, steroids, magnesium, maybe post-intubation sedation with ketamine due to the bronchodilation effect. So there are things that we can do on a vent, but the vent isn't going to completely solve the issue. We have to continue treatment with medications. So if we have anything that's kinked, whether that's the endotracheal tube, whether that's the vent circuit, anything that could cause obstruction with thick secretions in the tube. So remember, when you're going down your dopes, which we'll cover in the next slide, always suction your tube to rule that out. Make sure that you're looking and evaluating the patient's sedation status. If they're starting to overbreathe the vent, that's also going to lead to a high pressure alarm. That's usually a pretty easy fix. Resedate the patient. That way they can be more compliant. And then if you've set a volume that's too high because you overestimated that person's height, that could lead to a high PIP alarm. Anybody who has decreased compliance. So those are your really sick patients where their lungs are no longer able to comply with the volume you're giving them. People who are fluid overloaded, they have a lot of pulmonary edema, dialysis patients who have pulmonary edema from that, those patients are going to have high PIPs, and then a tension pneumothorax. So these are all the specifics of what could cause high PIP. So whenever I have an alarm going off on a vent, I always look at the vent. The vent will tell you right away what's causing the alarm. If it's pretty clear on what's causing the alarm, you can make adjustments. If it's reading a high pressure alarm or low pressure alarm, sometimes going through dopes makes you stop, have a systematic way of approaching it. That way you're not missing anything. So I usually will start from the vent, track my tubing all the way down to the endotracheal tube, making sure nothing is displaced or got knocked off. Make sure nothing's kinked in the tube. Make sure nothing's kinked in the vent circuit. This is where I would suction my tube. Re-listen to lung sounds. Make sure I'm not developing a tension pneumothorax. Check my equipment. Make sure there isn't anything wrong with my equipment. And then evaluate my patient's sedation status. Are they breath stacking due to lack of sedation, or is that obstructive patient with a history of COPD or asthma that we had to intubate for those reasons? Possibly breath stacking due to the fact that I don't have the proper vent settings for that patient. Something, again, we'll talk about a little bit later. So to reiterate what my approach is to a high pressure alarm, I always try to fix the underlying cause first. So these are things that you could probably find when you're going through your dopes. If you're able to find those things should hopefully be easily correctable. But if during the process of going through your dopes you don't find anything that is directly causing that high pressure alarm, the second thing I'm going to do is decrease the volume. By decreasing the volume, hopefully that's applying less pressure inside the chest, which should hopefully decrease my PIP, which means my high pressure alarm should start going away. Typically when I'm starting a tidal volume, it's somewhere between the 6 and 7 milligrams per kilo of ideal body weight. So I may slowly start dropping it down to that 5 mLs per kilogram, and hopefully that solves my issue. And then if I do the first two things and it's still not, correcting the high pressure alarm, I need to start thinking about underlying causes. Why did I intubate this person? Do they have acute respiratory distress syndrome, where the lungs are all inflamed and they have decreased compliance? Is this a COPD asthma patient where I'm going to have increased airway resistance? Okay. Does this patient have pulmonary edema, and that's why I'm having a high pressure alarm? And then overall, do I just have a patient where their lungs are just really have bad compliance? And if you can kind of identify what's possibly the underlying cause, it can be helpful with understanding why. And it may not be anything that we can directly do to fix it in the field. It may be something that the hospital has to fix over time. But it doesn't hurt to switch to pressure mode, because in pressure mode, you're protecting the lung. So you can switch to pressure mode, set your PIP, let's say somewhere between 30 and 35, which is on the high end of normal. And when you set that pressure, you're looking at the volume that the patient is pulling with that pressure. So let's say, for instance, I set the PIP at 35. With the PIP at 35, my 6-foot adult male patient is only pulling a tidal volume of 200. Well, looking at the chart, a tidal volume of 200 is not going to be sufficient enough to maintain a patient to the hospital. They're going to be losing a lot of volume with dead space, and it isn't going to be enough to actually have gas exchange. So if that's the case, I'll just switch back to volume mode. Basically what that just told me was I had a patient with poor pulmonary lung compliance. But let's say you do switch to pressure mode and you set that PIP somewhere between 30 and 35, and your tidal volume ranges are within an appropriate range to manage a patient. I may leave that patient in the pressure mode because, one, I can directly protect their lungs because I'm controlling the amount of pressure that is being applied to the lung. And two, I have adequate volumes to maintain adequate vital signs en route to the hospital. So these are just steps that you can take to kind of help you have a systematic way to approach a high pressure alarm, to be a clinician and critically think. All right, to kind of rehash things that we've already talked about, remember ventilation and oxygenation are married, but separate them in your head so that it's easier for you to understand what settings to change based off of the situation. So if they're not oxygenating well, your PEEP and your FiO2 are going to be the two things that you fix to improve oxygenation. Your respiratory rate and your tidal volume are going to directly affect ventilation. So when we're talking about getting a tidal volume, why are we doing ideal weight and not actual? Well, let's think about it. If you have a patient who's 6 foot and they weigh 300 pounds and a patient who's 6 foot and weighs 200 pounds, the person that weighs 300 pounds shouldn't get more volume just because they're a bigger person. Our lungs, our capacity of our lungs don't necessarily change based off of how much we weigh. So we want to provide adequate volume based off of their ideal weight to reduce any form of barotrauma that could occur because we're trying to estimate volume based off of actual weight. So our range should be somewhere between 5 to 8 kilos per ideal body weight. The chart that you have right here is what's typically on the vent inside of our ambulances. It's also in our protocol app. So if you look at the chart in detail, it has the height on the left. It has PBW is their ideal weight in kilograms, and then it has your range of 4 to 8, which typically we're between the 5 to 8. There is a math formula to get this. So if you didn't have this chart, you would have to do a math formula, which none of us want to do math in front of a patient. All right, we have a good understanding of what our tidal volume should be set at. Now let's look at respiratory rate. A typical respiratory rate range for an adult patient is between 12 and 20. Now I want you guys to take that and pretty much start in the middle. Start at 16 breaths a minute. Now this is just going to be for your generic patient that you intubated. If we're talking about a DKA patient or a COPD asthma patient, those are going to have different approaches, but for the most part, you should be able to start at a respiratory rate of 16, and that is a good starting point. And I'll kind of explain why that's a good starting point in the next slide. In our previous two slides, we talked about how to get a tidal volume and what a good starting respiratory rate is at. And that's going to help bring things together when we talk about minute ventilation. Now, your minute ventilation is the volume of air you're moving per minute. Most adults, it's between 4 to 8 liters a minute is normal minute ventilation. Now, minute ventilation is your respiratory rate times your tidal volume. Your tidal volume is the amount of air you're moving per breath versus minute ventilation is the amount of air you're moving per minute. The reason why this is important is because we want to ensure that the volume that we're setting is adequate enough to reach the alveoli and contribute to gas exchange, which will help oxygenate and ventilate your patient. So when we're not intubated, we're consuming about 60 mLs per kilogram a minute. So that's about 6 liters, which is right in the middle of that 4 to 8 liters a minute. But for somebody who is intubated, we're going to up that value to 100 mLs per kilogram a minute because we're adding a vent circuit and an endotracheal tube. Both of those things have dead space inside of them, and we will lose some of the volume that we're giving that patient through those pieces of equipment. So how does that apply to the settings that we're going to apply on a vent? Well, a normal 5'10" male is about 73 kilos, and that's something that you can get from your vent chart. If you took 73 and you multiply it by 100, that's giving you 7,000. And that is just a rough range. I know if you took 73 times 100, it'd be 7,300. But you can kind of round down or up a little bit. The point is 7,000 is the minimum minute ventilation that male, 5'10" male needs in order to ensure that we're getting enough volume down to the alveoli. Now, if you simply took 7,000 and divided it by your desired tidal volume, that's going to give you a respiratory rate. And typically, whenever you do the math, so say 7,000 divided by 450, 7,000 divided by 400, your respiratory rate usually falls somewhere between 16. So that is why in the previous slide I said 16 is a good starting point, because it's going to ensure that you're going to give an adequate minute ventilation for a majority of your patients. This is a visual just to kind of give you guys a wrap up of tidal volume and respiratory rate and how both of those multiply give you that minute ventilation. Remembering that your tidal volume is based off of ideal weight, your range is between 5 to 8 milliliters per minute, and then your respiratory rate, you have a range between 12 and 20, but if you start at 16, that's going to ensure that when you multiply that by your volume, that's giving you that adequate minute ventilation to overcome any dead space. Now, minute ventilation is still going to be an important topic, especially when we talk about pediatric patients a couple slides down the road. All right, should be pretty simple, but these are concepts that you can take not only for a patient who's mechanically intubated or a CPAP BiPAP patient. This is a concept that you can take when you're ventilating somebody with a BVM. Number one, the PEEP valve, something that is typically forgotten when we're ventilating somebody with a BVM. But don't forget to titrate up the PEEP valve as needed to maintain alveoli recruitment so that you're able to adequately oxygenate the patient. So if we're bagging somebody with a BVM, the PEEP valve should be set at 5. If they're intubated, your default setting is typically going to be 5. Now, I recommend going up in increments of 2. If you have a good understanding of what's going on with the patient, you can always increase that value as much as you feel is needed. But just like we talked about in the beginning of the PowerPoint, just remember that as you're increasing intrathoracic pressure, that has a direct effect on your hemodynamics. So if your patient's already shocky, going up on the PEEP too fast could cause you a lot of issues. So go up in increments to help you be able to recruit more alveoli. Then obviously increase the amount of oxygen in the solution by increasing your FiO2. I typically like to start off at 100%, and I will titrate that value down as needed, but we understand that too much oxygen over time is bad for a patient, it's toxic. In our short transport times, too much oxygen isn't directly going to hurt the patient, but just understand in the hospital setting, they will lower that value down to maintain an oxygen saturation of at least 94% or above. When we talked about minute ventilation, we discussed dead space very briefly, but if you didn't know, dead space is the volume that is not contributing to gas exchange. So it's being lost somewhere. And on a day-to-day basis, when you and I breathe, we're losing some of that volume due to anatomical and physiological dead space. But we're intubated now, we have a tube, we have a vent circuit. Those are all mechanical dead space that are added in, which is why the formula changed a little bit when we talked about minute ventilation to account for that dead space. So to give you guys a better understanding, 2 mLs times your PIP is going to be the dead space for an intubated patient. So if my PIP was 20, I took 2 mLs and times that by 20, that's 40 mLs. So basically take 40 mLs of that tidal volume, of that dead space, and subtract that from your tidal volume. So if my tidal volume was set at 450, really the volume that is actually getting to the patient is 410. Which for an adult patient, we have a lot of leeway there. It isn't going to affect us as much, but we need to be mindful of that. When we're talking about a pediatric patient, this is going to be very important because the tidal volumes for pediatric patients are a lot smaller. So a tidal volume for a pediatric patient is going to be 1 ml times your PIP. Remember that, especially as we go through these next couple of slides when we're talking about pediatric mechanical ventilation. The higher the PIP, the more expansion is happening in that circuit. That means more volume is being lost. That is why you start to lose some of the volume that should normally be given to that patient inside that actual vent circuit. So specifically, this slide is for intubated pediatric patients and kind of how dead space plays a huge factor into them. So the things that we don't normally think about are end-tidal CO2, which is on every patient who is intubated or being ventilated. We're not thinking about the amount of dead space that is being lost inside of these pieces of equipment. So you know that 1 ml times your PIP for a pediatric patient, you're losing some volume. Add on 10 mLs to that because you're going to have a end-tidal CO2 in line. And then the one on the right side of the screen, which has less than 1 mL of dead space, is a neonatal one. But just remember that because that is going to be very important when it comes to making sure that our settings are adequate enough to ensure that we're getting enough volume down for that pediatric patient. All right, so this little neonate that is intubated has an end-tidal CO2 filter, obviously has appropriate vent tubing. All of those things are leading to 4 mLs of dead space, which when we're talking about an adult patient, again, that doesn't seem like a lot. But when we're talking about a little neonate where their tidal volumes are super small because of their size, 4 mLs of dead space could be a lot if you're not taking that into account when you're putting them on a vent. All right, so what mode of ventilation is preferred in a pediatric patient? So just for you to understand, you can use either volume or pressure mode. Either one of those modes you can use. And we're going to go over in the next couple slides how to do that and what resources we have to help you guys figure that out. But you're probably going to want to stay in pressure mode. It is the safer mode and is the most preferred mode when we're talking about mechanically ventilating a kid. Pressure mode does a great job of protecting the lungs. It makes sure that you're not exceeding the pressure inside their small chest cavity. But it's also taking into account the dead space. The vent will consider the pressure needed to produce that volume in AC pressure mode and overcome any dead space. So the tidal volume that's being produced in pressure mode is the actual volume that is getting to the patient. So what that means is that dead space that we talked about in the previous slides that we need to be worried about, well, in pressure mode, it's going to overcome that dead space, and the volume being produced in pressure mode is the actual volume getting to the patient. So the charts that we have currently posted inside the ambulance or in our protocol app are an easy tool to use in a pressure situation that you can just follow what's written on here, plug in the settings, hook it up to the patient, and hopefully you don't have to do anything the rest of the transport. So this chart specifically is talking about AC volume mode, and in AC volume mode, you're setting the volume, and based off of the volume creates a pressure. Now the volume is again still based off of ideal weight, and that can be found based off of HANTEVI and whatever you feel, not whatever you feel, but whatever is the ideal weight of that patient based off of the app. You have your tidal volume range that is set right there. Your peak inspiratory range has a range between 15 and 25, and then you can set your respiratory rate based off of the chart and the age of the patient. Pressure mode. This chart says pressure mode is more for lung disease. Again, pressure mode probably should be used for every pediatric patient. I'm just kind of reading what the chart says. You can decide what you want to use, whatever you feel comfortable with in the moment. But in pressure mode, remember you're setting the pressure and that creates a volume. So your peak inspiratory pressure should be somewhere between 20 and 30, or whatever is the lowest number to give you that good tidal volume, that adequate expansion. The tidal volumes that is being produced should be somewhere between 6 to 8 milliliters per kilogram. Your respiratory rate doesn't change. You set that based off of what's listed. And then your inspiratory time, which is something that you can directly dial in, is listed on there based off of the patient's weight. Your PEEP and FiO2 don't change. So very simple, easy tool to use so that you're not trying to remember everything you were taught. You can look at it, look at your protocol app or look at the chart on the wall and dial in these settings. So for any patient who you are having to intubate due to a history of COPD or asthma, you want to apply an obstructive approach. An obstructive approach, basically, you're allowing the patient more time to exhale. And the reason why you want to allow them more time to exhale is because they're very high risk for auto-PEEP. So auto-PEEP is essentially breath stacking. So as you're giving them a volume, before they've even completely exhaled, they're already receiving another volume. And the reason why they're taking longer to exhale is because they have a much more narrow airway. So our whole goal with them on a vent is to increase the expiratory time. So change our IDE from 1 to 2 to 1 to 3, which the vent defaults at 1 to 3, to 1 to 4 or 1 to 5. That 4 or 5, the very last number in the IDE, is your expiratory time. And we want lower respiratory rates. So instead of a respiratory rate of 16, we want to be somewhere between 10 to 12. The reason why that is if you think about it, the faster you breathe, the less time you have to exhale, versus the slower you breathe, the more time you have to exhale. So lower respiratory rates will help with offloading more CO2 and decrease the risk of auto-PEEP. So further looking at the obstructive approach, your tidal volume range is still relatively the same. I would encourage you guys to be on the higher end of the tidal volume range, somewhere between 7 to 8. The reason why that is because you want to make up for the loss in minute ventilation due to a lower respiratory rate. So instead of the respiratory rate being 16, it is now 10 or 12, which drops your overall minute ventilation. So you need to make up for that by increasing the tidal volume to somewhere between the 7 to 8 milliliters per kilogram of ideal body weight range. Again, your IDE ratio changes from 1 to 4 or 1 to 5, and your PEEP should be somewhere between 3 to 5. Now, I'm not saying withhold PEEP, but if you think about what's going on, you have air trapping inside the actual chest. That is probably contributing to physiological PEEP, meaning they already have a lot of air being retained. So going up on the PEEP because you think that this is an underlying oxygenation issue could make that patient worse. Your COPD asthma patients, remember, are underlying ventilation issue. They have a hard time getting air out, which eventually leads to a hard time getting air in. So our job is to give them medications to treat that, and then if we have to intubate them, use an obstructive approach to help fix some of these underlying issues. So PEEP isn't necessarily the first thing you should be jumping to in these patients. It should be your respiratory rate and your IDE. And obviously, these patients, especially your COPD patients, learn to breathe at lower oxygen levels. So you can start off at 100% FiO2, but in the hospital, they'll probably try to narrow it down to a 40–60% range. And then we just need to make sure that we're continuing pharmacological treatment. So continue dual nebs, continue max sulfate drips, epi drips if needed. Make sure you've given some Dex, and then ketamine is a great pre-intubation RSI medication to use and a great post-intubation medication to use because of the bronchodilation effects of ketamine. All right, let's start off with a scenario to hopefully bring everything together. You're dispatched to a scene flight. So kind of put yourself in a mindset you're a flight paramedic for this particular scenario, and you're dispatched to a 4-year-old female. It's been ejected approximately 8 feet. Their ideal weight's about 20 kilos. So you and your partner get on scene, do a quick assessment. Patient has head trauma, they're altered. So you decide to intubate the patient. You successfully intubated, you have good vital signs. So kind of stepping away from a vent lecture, let's talk about head trauma. So a very basic concept that everybody should put into their brains is the 3 H's and the things that we have to prevent when it comes to head trauma. We don't want to allow anybody with a head injury to get hypotensive. We don't want to hyperventilate, so we want to keep an end tidal between 35 and 40. And we don't want hypoxia to occur. If we can avoid those 3 things from time we make contact to the time we drop them off to the hospital, we're going to help improve the patient's overall outcome. And then when we're transporting somebody, we typically want to transport somebody with a head injury with their head sitted up so that gravity is allowed to do its thing so that it's not just a bunch of blood pooling inside of the brain with them laying flat. So that's going to help drop intracranial pressure. All right, but back to the vent lecture. What I want you guys to do is place this patient on the vent. Okay, use your resources, use what you just learned to place this patient on a vent. Okay, so this is your time to pause this video, write down your vent settings, and then we can continue on. All right, so I put this patient in volume mode. I set the rate at 22. I put the volume at 120. My PEEP is 5, but I'm getting a high pressure alarm right now. My PIP is 40. So anytime we get a high pressure alarm, we talked about stopping, running through dopes, okay? So nothing is displaced. I make sure no tubing is obstructed. I suction the tube, all right? Pneumothorax is something I'm going to be highly suspicious of just based off of the mechanism of this patient being ejected and chest trauma. And then I'm going to look at my equipment, and then I just intubated this patient. I use ROC, so there's no reason why this patient should be breath stacking, okay? Once I've ruled out the things that I can fix, then I'm going to think about maybe adjusting my settings. But in this particular patient, they are developing a tension pneumothorax, and that is why my high pressure alarm is going off, something that you would catch if you do go through your dopes. You should stop at that P and hopefully look for those signs of a tension pneumothorax. All right, now let's answer some questions. Is this an obstructive approach or an injury approach? An obstructive approach is essentially what we just got done talking about a couple slides ago. Patient who has a history of asthma or COPD that we're having to intubate, and we're having to make changes to improve the amount of time they're exhaling. That is not this patient. Every patient other than an asthma or COPD patient that we're having to intubate for those reasons falls underneath the injury approach. The injury approach is essentially using the least amount of volume necessary to have adequate chest rise and fall and adequate vital signs. So this patient is going to fall underneath that injury approach. Are we using PD tubing or adult tubing? Now this is something you can very easily reference in your protocol app, but I would encourage each one of you to put this into memory. Your PD tubing is tidal volume range for that tubing is between 50 and 300 mLs. So if you took this patient whose tidal volume is somewhere between 100 and 130, and you put them on adult tubing, what do you think is going to happen? Well, hopefully you understand that that is nothing but dead space with adult tubing at a tidal volume that is lower than what is normally set. For adult tubing is somewhere between 200 and 2000. So once with adult tubing you drop below that 200, there's going to be a considerable amount of dead space, and you're going to see some clinical signs in which your patient is getting worse. So hopefully you're keyed in on the fact that you used the wrong tubing and you can switch over to PD tubing. And then we talked about in the previous slide how to review the causes of high PIP. Hopefully you have a good understanding of that. If you don't, please reference back to the beginning of the PowerPoint in which we talked about how to maneuver through that. And then obviously the primary treatment for this situation is going to be needle decompressions. All right, scenario 2. You respond to a scene flight. So again, put yourself in the mindset of a flight paramedic. All right, but let's just say this is a patient that isn't in the hospital and is somebody we're picking up off the street and having to intubate. Just whatever mindset helps you. I'm going to add in some hospital stuff just to kind of give you guys some more knowledge, but the baseline understanding should be the same. So the nurse tells you that the patient's ABG is getting worse. The pH is 7.12, the CO2 is 80. Okay, so for those that don't understand ABGs, that's fine. But the patient is in respiratory acidosis, secondary to why they were intubated, was just that history of COPD. So their current vital signs are heart rate of 140, a blood pressure of 150/94, a respiratory rate of 38, O2 saturation of 88%, and an end tidal of 70. So they're hypoxic, they're tachycardic, they're tachypnic, and they're hypercapnic. Okay, so there are a lot of things going on with this patient. So you go over, you look at their vent. You notice that they're in AC volume mode. Their tidal volume is 500. Their respiratory rate is set to 25. They have their oxygen, their FiO2 maxed out. They have their PEEP at 5. They have their IDE at 1 to 2. And their PIP on their vent is reading 50. I want you guys to take a second, stop, pause it, think about what's going on. Okay, I know there's some things that haven't been given to you as far as meds, but just look at the vent settings, look at their vital signs, the brief ABG that you got, and I want you guys to critically think about what changes you would make. So the current ABG, so this is the ABG that we've asked for at bedside, has a CO2 of 88, so it's gone up 8 points, a PaO2 of 230, so we're getting a lot of oxygen in, okay, and we have a bicarb of 26. That is just painting a respiratory acidosis picture. So hopefully you've thought about it and you recognize the issues that are at hand, okay? This is something we're going to touch on a little bit more in the next slide. Lung injury approach or obstructive approach? Hopefully you guys are automatically jumping to the obstructive approach. That is the approach that we need to use for this patient. So obstructive approach is for anybody who has a history or COPD that has had to be intubated for that reason. So are we protecting their lungs with the tidal volume or the respiratory rate? Hopefully you guys remember that we are protecting their lungs with lower respiratory rates so that we are allowing them enough time to exhale. If you remember in the scenario, the respiratory rate they had set at was 25, but the patient was breathing 38 times a minute. So both are extremely high respiratory rates, and there's a couple reasons why there's discrepancy between what's being set and what the patient's actually doing. But at the end of the day, both of those things are not helping this patient out. So lower respiratory rates, and you need a longer E time. So we need to extend their IDE ratio. So overall, why do you feel like this patient's ABG got worse? Or why aren't they improving despite the fact that they've been intubated? A couple different things. Number one, this patient is not adequately sedated. That is why their heart rate is so high. That is why their respiratory rate has discrepancy where the vent is set at 25, but the patient's doing 38 times a minute, okay? So one, we need to sedate this patient. In order for us to do anything, we have to have adequate sedation so they can be compliant with the vent. You got to think they're on AC mode, and if you remember, AC mode is not a great mode for a spontaneously breathing patient because there is an issue where if you're not in synchroncy with the vent, you could cause breath stacking. So this is a patient I would hit with ketamine right off the bat. Ketamine is going to help sedate, treat the pain, and then also get bronchodilation. The other reason why the ABG is getting worse is because they have terrible vent settings. They're not protecting their lungs by giving them lower respiratory rates and longer IDE times. Their IDE time was 1 to 2. So we sedate this patient, we make some changes on the vent, we should start seeing this patient ABG improve and their overall presentation improve just based off of some simple basic concepts that you learned in this lecture. So they're air trapping from two different reasons. One is the inadequate sedation, so they're not in sync with the vent, and then two, they're not allowed enough time to breathe out before the next volume comes in because of how obstructed their lungs are, leading to further air trapping. So all of those things lead to poor ventilation and lead to retention of that CO2. And then if you're able to, if we're talking about switching to different modes, on our vent, we really can't switch to any other modes besides pressure, but this is probably a patient where SIMV mode, which is a mode that is typically used in the hospital, will be the better mode because it would allow the patient to spontaneously breathe on their own, provide support, but not contributing to the breath stacking that is occurring. All right, scenario number 3. You dispatch to a 40-year-old male for shortness of breath. You find the patient unconscious, they're breathing shallow, they're breathing rapid, lungs are clear, pupils are good, radial pulses are good and strong. So we don't know this for sure, but our neuro looks to be, decent from what we can see. We don't have any dilated pupils. We have good lungs. We're not dealing with like a respiratory issue. We have good pulses. We're not really dealing with like a shocky patient. So that's all good information. But they have a past medical history of type 1 diabetes and they're breathing deep and rapid. So there's something kind of pointing us in a direction of, is this a diabetic emergency? These are our vitals. So we're hypoxic, we're tachypnic, we're tachycardic, hypertensive, our end tidal is very high, and our blood sugar is reading high. So hopefully you're understanding that this is a DKA patient. This is a DKA patient who can no longer compensate for themselves because a normal DKA patient has Kussmaul respirations, and those Kussmaul respirations are supposed to offload CO2 to help offload a respiratory acid to help try and compensate for all the metabolic acid that's building up from all the ketones. So once a DKA patient is no longer able to compensate for themselves with their respiratory drive and they're starting to progress towards respiratory failure, which is marked by their end tidal going up, then becoming hypoxic, and now they're at the point that they're unconscious, you have no choice but to take over their airway. And once you take over their airway, we have to have a basic understanding of physiology so that we can have adequate vent settings so we're not killing them on a vent. So hopefully your differential was DKA. What's going to be your vent settings for this patient? Are we just doing generic settings, or are there some things that we need to change so that we can compensate for this patient? So basic review, DKA versus HHNS. So HHNS is typically your type 2 diabetics. They're not going to have any respiratory changes. They're not going to have any ketones built up. They are your very dehydrated patients who are slightly altered. Your DKA patients are the ones where ketones are actually being developed. Those are the patients who are very insulin dependent. Those are your type 1 diabetics. And what you'll see in a DKA patient is as that acid starts to build up, their respiratory rate will change where they get those Kussmaul respirations. Okay, so that's probably like the biggest difference between DKA and HHNS is that DKA has those respiratory changes and they actually have acid building up inside their blood. Versus HHNS is just more of a very dehydrated patient who's lethargic and needs fluids and insulin. But that's kind of the basic difference between the two. All right, so to just kind of reiterate some things that I've already said. This is a metabolic disorder. You have to be able to compensate for these patients by breathing deep and rapid and blowing off CO2. So your vent settings are going to have to match that. So your goal is to keep an end tidal CO2 on the lower end. It isn't necessarily going to be in this situation to make their end tidal CO2 normal. So this isn't something that you need to remember, but it's just a guide to kind of help you guys choose adequate vent settings. 2, you remember the minute ventilation formula, which was 100 mLs per kilogram a minute. This formula is now 240 mLs per kilogram a minute for that DKA patient, so that you can maintain proper pH and protect them by having an adequate minute ventilation to offload as much CO2 as possible. So if you took a 70 kilo patient, this is based off of their ideal weight, which you can get off the chart, multiply that by 240, that's going to give you a minute ventilation of 16,800. Divide that by the volume you're starting at. So let's say we're starting off at a volume of 450. That's going to give you the respiratory rate needed to achieve that minute ventilation so that we can help that patient compensate while they're intubated. Now, I get it, we don't want to do math, so here's a very generic kind of cheat sheet for you guys. Still start at a tidal volume range somewhere between 7 to 8, so find that on the chart based off of your estimated height for that patient. And then your respiratory rate probably should be between 25 and 30. Stevens doesn't really want us to get above 30 just because that's going to cause too much vasoconstriction inside the brain because we're hyperventilating too much. So we kind of want to keep that between 25 and 30, and that should hopefully be enough to help that patient compensate to the hospital where they can start fixing that underlying issue that we can't address in the field, which is insulin, but we obviously can give fluid. And just a good understanding is any change of end tidal CO2 by 10 is going to swing your pH by 0.08. So if you intubate a DKA patient and their end tidal before you intubated them was, let's say, 20, and you put them on the vent and you start them at 450 at a rate of 12. Okay, everything's good, vital signs are good. Your end tidal comes back at 45. You're all right, that's a little bit high in the normal, but I'm fine with that. Or if you just did that simple math, you just swung that pH and made it lower, even though you think your end tidal is good because you have it within an appropriate range, you're just further helping that patient probably get worse, if not possibly code, because you're not offloading the CO2 that was needed to help that patient compensate and stay alive. So this is the kind of patient where you don't want to intubate them unless you have to. And in this scenario, you had to because they were going into respiratory failure and were likely to code. And you just want to have a basic understanding that my respiratory rate needs to be higher to help them offload CO2. Thank you guys for listening and going through this lecture. Hopefully you found it helpful. Please follow up with questions if you feel like nothing was clear or you just want some more hands-on practice.